All right, team, gather around. Welcome to today's Clinical Explainer. We're running a shift debrief on a really high acuity case today, Elena Petrova. We're going to use this patient simulation to really sharpen our clinical reasoning and our crisis management skills. As your senior charge nurse, I need you to look at this not just as a timeline of what went wrong, but as a masterclass in anticipating the drop before it ever happens.
So, here's our game plan for Scenario 3. We'll meet Elena and check her baseline, analyze some serious red flag lab values, pinpoint the exact moment she deteriorated on the ward, tackle our DIVA crisis, that's difficult IV access, and wrap up with our isobar handover. We've got a lot to unpack, so let's jump right in.
Section 1. Meeting Elena and establishing her clinical baseline. You know the drill. You absolutely cannot recognize a patient crashing if you don't know where they started.
So here's what we were up against on the floor today. We've got acute decompensated heart failure, rapid AFib, and a massive headache for us, DIVA, or difficult intravenous access. Honestly, any single one of these keeps you on your toes, but all three together, that is a perfect storm just waiting to happen.
Let's trace her steps. For 10 days, she'd been reporting increasing breathlessness. Then, bam, 4:30 a.m., the ambulance arrives. She's sitting bolt upright, gasping for air, with her oxygen sats sitting at a miserable 89% on room air. Down in the ED, they managed to push 80 milligrams of IV furosemide. But get this, they could only get one single tiny 22-gauge line into her arm because her veins were just that shot. And that sets us up for 13:15 p.m., when things really go south.
Now, to understand why she crashed, look at her history. Elena is 82. She lives with her daughter, Maria, who is super involved, which actually becomes a major plot twist later on. Her background is basically a medical minefield. Congestive cardiac failure with an ejection fraction of just 30%. She's got permanent AFib, meaning she's on Warfarin, and stage 3B chronic kidney disease. It's a highly compromised baseline, right? The deck is already completely stacked against her.
Moving to Section 2, analyzing those critical lab values. These labs from the ED are the giant flashing warning signs that created a classic Swiss cheese effect of compounding risks.
First up, check out this BNP level, 1,850. Now remember, a normal level is generally under 100. So 1,850? That is not just a little fluid retention. That confirms a massive heart failure exacerbation. Her heart is under immense strain, and she is severely fluid overloaded.
And here's the real curveball. Her INR is sitting at 4.2. Because of that AFib, she's taking Warfarin, but at 4.2, she is dangerously super therapeutic. Her blood is incredibly thin, meaning she's at massive risk for bleeding from even the slightest little trauma.
So, connect the dots with me here. We have a documented INR of 4.2, a huge bleeding risk, paired with known difficult IV access. Think about what that really means. It means that losing our one and only 22-gauge line isn't just an annoyance, it's an absolute danger. We literally can't just keep fishing around for a new vein without turning our arm into a massive bleeding hematoma.
All right, Section 3, acute patient deterioration. This is the big turning point of the shift, where one totally innocent event triggers a complete clinical nosedive.
Let's zoom in on 13:15 p.m. Elena's daughter, Maria, bless her heart, she means well, brings in this homemade soup, but it is loaded with sodium. For a patient with an EF of 30% and a BNP of 1,850, that salt load is basically pouring gasoline on a fire. Boom! Suddenly, Elena becomes orthopneic, she turns ashen gray, and she's dripping with sweat. Listen to how fast these vitals spiral. Her heart rate skyrockets to 155, her blood pressure spikes to 175 over 100, she's breathing 32 times a minute, and her SATs plummet to 86%, even with 4 liters of oxygen flowing.
She is crashing hard. Severe pulmonary edema, rapid ventricular response, and she desperately needs immediate IV meds like aggressive diuresis and rate control. But I need you to pause right here and anticipate the absolute worst-case scenario. What are we going to do if our only line, that little 22 gauge we fought so hard for, suddenly fails?
Which brings us to Section 4, managing the DIVA crisis. Let's break down exactly what we do when our worst nightmare becomes reality in the middle of a code.
And here is the harsh reality of nursing team. Right at 13:15, while she's gray, sweating, and her heart is hammering at 155 beats per minute, that single 22-gauge line in her right arm gives out. It has tissued, completely blown.
Elena needs life-saving IV meds this very second, and we have absolutely zero access.
So, as junior nurses, how do you handle this? Let's walk through it together. Step 1 is pure recognition. You see the tissued line, and you know she needs meds instantly. Step 2 is where your situational awareness kicks in. You have to remember that 4.2 INR. You absolutely cannot try blind IV sticks right now. You'll just cause massive bruising. Which means step 3 is rapid escalation. You don't try to be a hero with a needle. You immediately escalate for ultrasound-guided access or even an IO, intraosseous access. You get the right tools right now.
Finally, Section 5, executing the ISO bar handover. When the room is spinning and everything is going wrong, your communication has to be completely flawless.
We use the ISO bar handover framework. This is our gold standard for a reason. It cuts out the fluff, stops the guesswork, and makes sure the rapid response team knows exactly what they're walking into the second they arrive at the bedside.
Let's break down exactly how this sounds in practice. I is for identify, Elena Petrova, 82. S is situation, acute pulmonary edema, rapid AFib, and a recently tissued IV line. O, observations. Vitals are crashing. Heart rate 155, BP 175 over 100, respiratory rate 32, SATs at 86%. B, background. She's got heart failure with an EF of 30%, chronic kidney disease, and crucially, an INR of 4.2. A, assessment. Severe fluid overload with critical loss of IV access in a known DIVA patient. And R, recommendation. We are activating a MET call, requesting urgent ultrasound-guided or IO access, followed by aggressive diuresis. Boom. The whole story, perfectly packaged in under 30 seconds.
So, I want to leave you with a challenge for your next shift. When you get a patient with documented difficult access and a wildly super-therapeutic INR, what is your backup plan before that line fails? Because in nursing, hope is not a strategy. You have to anticipate the crash, protect your lines, and always stay one step ahead. So, what's your plan going to be?